We will go ahead and get started. So today we're very honored and happy to be joining Dr. Wilson Morris in learning about some of the palliative care skills, including discussions with family and patients. Dr. Wilson Morris is our division director for the palliative and hospice division, and she is also the fellowship director of that same fellowship, where she's been getting all kinds of awards for several years as an excellent educator. And I've been really, really happy and impressed working with her so far as a division director, leading a lot of meetings, data gathering, advocating, faculty development. She's doing a fantastic job. She really is doing it all. So go ahead, Amanda, take us away. You are muted. There you go.
Okay, seeing everything okay?
Slides look good.
Perfect.
Yep.
Okay. So for our conversation today, I wanted to talk about something that's pretty common to all of us in the medical community. Wanted to talk about some of the basics and fundamental, concepts of communication, but there's been a recent debate that has exploded in our community. It's been brewing for a while. It has risen and subsided, and we're back to that debate again. And so I really wanted to talk about what is it all about. Some may be familiar with it and maybe not, but I do think it's relevant to patient care, to good care, to quality care, which is, what we want to focus on as medical providers. Uh, in many ways, what we do in palliative care is providing clarity for our patients, wanting to help our patients and families understand the limits and the possibilities of their treatments options, helping clinicians as well develop approaches to care that is consistent with patient values. And so I want to bring to this topic to talk about the best way to approach these conversations, and then probably talk a little bit about a framework of how it's currently being done and what the thoughts are about it. So the objectives today to review the scope of palliative care, which may be familiar to most and to many of us, define advanced care planning, and talk about this shift towards what we are now calling serious illness conversations. And I do not have any disclosures. So what is palliative care? I think it can be hard for our providers, for lay people, for patients, and for anyone to understand the gamut of what palliative care is. It really is a very broad category. This is one of my favorite cartoons about palliative care because it really depends on what lens you're looking through. We do so many things here in palliative care. But palliative care is for specialized medical care for patients with serious illnesses. It focuses on providing patients with the relief from their symptoms, their pain, the stress from a serious illness. And the goal is really to improve quality of life for not only our patients, but for their families as well. And so, as you can see, we're looking at a unit here, our patients, their families. It is appropriate at any stage and at any age in a serious illness, and is provided along with regular or disease-directed therapies. And so there is no definitive, reference here to prognosis. It really is about the serious illness that someone is facing. And so it's relevant to all of us as providers, no matter what subspecialty we're in, and no matter where you are in practice. So inpatient, outpatient, and skilled facilities and long-term care hospitals, palliative care, and the concept of taking care of patients at any stage of their illness is really relevant, regardless of who your background in your field. What is a serious illness? It is a health condition that carries a really high risk of mortality and either negatively impacts a person's daily function, their quality of life, or excessively strains their caregivers. There's been a lot of debate and talk lately about how much we have to focus on our caregivers and the burden that serious illnesses are placing on them, because again, this is a family unit, and it not only puts a burden on our patients, but it also strains their caregivers. And so a serious illness can be defined by that high risk of mortality that is basically affecting quality of life for patients and their families. So this is a common diagram that we've seen change and morph throughout the years in palliative care. It's a diagram of the interface between disease-directed therapies and then palliative care. And what we see is that as the disease progresses, the importance of palliative care increases. So think of a patient who has a lung cancer, who's undergoing chemotherapy and radiation, and this patient is likely to have worsening pain, they're likely to have symptom distress, and they are in need of aggressive symptom management. This is where palliative care steps in to help make sure that these therapies can be tolerated as best as possible. And at some point, this patient will no longer respond to a second, a third, or whatever line therapy, and then they will begin that transition from being really sick to actively dying or needing to transition to a hospice or an end of life scenario. And that's where we see more of the specialized palliative care coming into play. Palliative care involvement in these patients, where we're seeing increasing need, increasing support, has been demonstrated to improve quality of life. It decreases healthcare utilization. And the surprising thing for many, but we know about in the palliative care world, is that it does prolong life. And we've got trials and data that have proven this. One of the landmark trials that we know about is done by Temmel. It was done a while back, and it looked at 151 patients with metastatic non-small cell lung cancer. And it randomized them to usual care versus usual care with palliative care. And this was done at the beginning of diagnosis, so at least within 8 weeks of their diagnosis. And this study actually shows that palliative care involvement improved quality of life, or the patients had less depression, less aggressive care at the end of life, and surprise, they had longer median survival. And this is something that we have known to be true because palliative care is meant to aid in quality of life. Good quality of life can mean longer survival. Another study done by Connor looked at a pretty large population of patients from over 4 years, and it demonstrated that there was longer survival for specific populations of patients in hospice versus matched non-hospice controls, specifically for heart failure, for lung cancer, and for pancreatic cancer. And this is typical for what we see in our own clinical experience, where we're seeing patients who are getting aggressive medical therapies in the setting of dying, whether they're in their early stages or they're actively dying. And these therapies can actually shorten their life because they're overwhelming what is considered to be a already fragile physiological system. So being able to give them great care and comfort care can actually prolong survival. Why do organizations need palliative care? So there is a concentration of risk for poor quality and spending that lies in a very small subset of our patients. At times, at one point, we knew that there was probably around 10% of Medicare patients that were responsible for 60% of all the costs, and that's just a small subset that's occupying quite a bit of cost. There's strong evidence that palliative care obviously improves quality. There's improvement in satisfaction and decreased costs. And there are very few strategies that, while are improving quality of life, will actually reduce spending at the same time. So organizations are very interested in how palliative care can help improve patient care, but also make costs more manageable. So the scope of palliative care that we usually see that's provided by a traditional palliative care service are conversations about goals of care, advanced care or future planning, family support, patient support, symptom management, and then talking through complex decisions, whatever they may be. We're going to talk a little bit specifically about advanced care planning today, which is the conversation that's out there right now. And what is advanced care planning? This is a process that frames a discussion of what the patient and their family understand about their current state of health. It explores what is most important to them in the context of their illness. The goal is to ensure that the care that we're providing for them now and in the future matches their wishes It requires our patients to have medical decision-making capacity, and this is, we're talking mostly the adult population. There's some nuances with obviously the pediatric population, but it requires our patients to be involved in these discussions, and generally speaking, occurs prior to a healthcare crisis. So this is us saying, hey, this is happening or could be potentially happening. Let's talk about what could happen in the future. Advanced care planning conversations typically result in the completion and or updating of advanced directives. This can include designating a surrogate, someone who's going to help speak for them when they're no longer able to speak for themselves, coming up with living wills, post orders for those states that have the availability to do so. The great benefit that has been out there right now is that it's reimbursable as a Medicare benefit. And so we have the incentive to have these conversations, both inpatient and outpatient, on almost an annual basis so that we can stay connected with our patients and update what their wishes may be. And these conversations can happen by physicians, nurse practitioners, PAs, social workers, any healthcare personnel. There are often challenges, and I think we see these day to day, and we're often trying to figure out how to improve on these challenges. Some of the most common challenges are that they're all based off of hypothetical scenarios. And so we often have people having these conversations where they're checking a box on a living will and trying to align it with, have you seen something on television where you saw someone who was in an artificial state, or someone who wasn't going to wake up or recover? Have you had a friend or a family member who's gone through this? Many times they're having these conversations and completing living wills, if you will, with a lawyer. And so it's a templated document and that hasn't been fully fleshed out. Sometimes our patients are very ambivalent about, these issues. They have difficulty predicting what they want in future circumstances because, these predictions, they don't reflect what they're currently feeling, what their current medical status is, or their social context. And so it can be really hard for them to foresee the future. I had a patient a few weeks ago, and the timing was ironic because I was doing a lot of research for this talk, and she has small bowel cancer, and we were talking about her resuscitation status. And the more information she felt like she was getting, the more she just felt like she wasn't going to want to go through aggressive therapies, didn't want to be resuscitated, but she was pretty functional. And I encouraged her, as she completed her healthcare surrogate, to let her surrogate know, because often, as the last bullet notifies, healthcare surrogates, they're not often aware of their role. So as we talked it through, she made the decision for DNR, and I just reminded her that I was available to talk. And by that afternoon, she called our team back and she said, hey, I talked to my sister, she's my surrogate, and she doesn't want me to do the DNR, so I don't think I'm going to do it. And we had a conversation, and we were respectful of her decision, but her decision throughout the whole admission wavered. And so we saw her go through many days of being full code, and then before we knew it, she was going back to saying, forget that, I want to be a DNR all over again. And so they can be completely ambivalent and not necessarily confident in the decision making that they're making in those moments, because they're not quite sure what they're really going to be feeling, what they really want, and because their families are a great impact in their decision making. Advanced directives are often not available when needed. A lot of the times, as I mentioned, they're in a lawyer's office or they're in another hospital. We often have patients come into our Tampa Bay area from all over Florida, and we have to be calling around looking for advanced directives from different hospitals or different systems. And they don't come with a rubric of the conversation that happened around it. It's just check boxes, and they're often not very clear in what the patients were trying to share here, especially when they seem to be contradicting themselves a little bit in the documents. So there are some serious challenges that we've recognized with advanced care planning over the years. So despite the challenges, and advanced care planning sounds like a great idea, especially when you're in a network where you are, tied into our system, for example, USF system, where we can see the outpatient notes, we can see the conversations, we're we can see the documentation and whether they've been upgraded or not over the years. Why is there such a big question about advanced care planning, and what prompted it? Give you a little bit of history here so we can understand where the debate came from. In 1990, there was a patient self-determination act that came out that required all medical institutions to inquire as to whether a patient executed an advance directive and document their wishes. They also wanted to ensure that legally valid directives and documented medical care wishes were implemented to the extent permitted by the state. So we have this nationwide act that comes out that says you must get advance directives and document them and put them on file. Fast forward 4 to 5 years later when we had this support study, and it looked at national data on the experience of advanced illness in 5 tertiary care teaching hospitals. And it looked at a really large population, at least that I think 9,000 patients with life-threatening illnesses. And they did it in 2 phases. The first phase was an observational study, and it basically highlighted that, despite this intervention that was mandated, we are having a lot of shortcomings in communication. Patients were having moderate to severe pain more than 50% of the time while they were admitted. And a good chunk of our patients who died spent more than 10 days in an ICU. They were in a coma or on a ventilator. So despite having this idea that we should have these advanced directives out there, we saw that there were some serious challenges there. The next phase of the trial looked at the interventions of having advanced directives available, knowledge and focusing on pain control, having conversations about prognosis, and there was no effect with having these types of information and conversations on patient-physician communication, and that there was no improvement in the care or patient outcomes. So this is big, this is huge. It's challenging the notion that some of this information that we should have should help us in taking care of our patients. And so that was, in 1994, 1995. And fast forward even further to last year. And over the years since that time, there's been a lot of research done about advanced care planning. How can we make it better? How do we best implement it? How do we make sure that we're documenting the outcomes and making sure that we're getting the benefit that we intended? And so this article was written by Morrison, Meyer, and Arnold, and I came across it after it was sort of shared within a couple of friends of ours in our palliative care circle in a podcast. And Sean Morrison, there's been a lot of articles refuting it, obviously, but the question was, what's wrong with advanced care planning? And one of the pioneers in palliative care, Diane Meyer, who was the founder of our CAPC organization, Center to Advance Palliative Care, she is one of the authors on this article. And they basically questioned advanced care planning and is it meeting the need that it was intended to? A couple of points that the article raises based off of all the research that has been done is first, advanced care planning does not improve end-of-life care, nor does its documentation serve as a reliable and valid quality indicator of an end-of-life discussion. It also stated in there the inability of advanced care planning to achieve its desired outcomes represents the gap between hypothetical scenarios and the decision-making process in clinical practice settings. And so this is something that we've, had an idea about. We wonder how to continue to make it better. Another point raised was that patients' preferences, they're really rarely static. They're often influenced by someone's age, their physical and cognitive function, their culture, their family preferences, like my recent patient, the clinician's advice. We often hear patients saying, I want to hear first from my cardiologist or my oncologist. I want their opinions first, their financial resources, and then caregiver burden. There's a lot of things that influence our patients' preferences. And, a lot of the points from the article, were very valid, but it made us question what exactly is wrong with advanced care planning. They also raised in the article that some research shows that advance directives are often misinterpreted by physicians, families, and surrogates, and that new research focused on training physicians and preparing families and patients to engage in high quality discussions when actual medical decisions must be made is needed to achieve the outcomes that advanced care planning has not. And one of my questions from this article was, how do we improve on advanced care planning? I've got the sense from listening to all the podcasts from all the authors of the article that they were searching for more, right? A lot of the data was telling us that it wasn't doing quite what we hoped for. And so how can we push the boundaries? How can we make communication more effective? So not saying that, advanced care planning is not something that is needed, but how do we improve and how do we elevate our conversations so that we're doing a better job of this and achieving the outcomes that we want? This conversation led to the discussion of what could that conversation be, and serious illness conversations has led the way as that alternative that we're hopefully been looking for. So I wanted to raise a patient's case that can probably help shed a little context for some of this. Had a patient this month, 66-year-old female with stage 4 non-small cell lung cancer. She's status post chemo and radiation therapy. She presented to the ED with acute respiratory failure requiring BiPAP support. It was de-escalated to nasal cannula. Her chest CT revealed that she's got progression of her disease primarily in her lungs, and she's got an AKI. So she's definitely admitted to the hospital for medical optimization. And palliative care is consulted, and the question is help with advanced care planning. And is this a goals conversation? Is this an advanced care planning, or is this a deeper conversation that needs to happen to make sure that we're giving the benefit of this patient great care? So what are serious illness conversations? Let's talk about it a little bit and then we'll reflect back on this case. Serious illness conversations, they focus on the patient's current illness experience. Usually it is preferred to have discussion with a trusted clinician or a provider who understands the medical aspect of the serious illness. And then the importance of creating safety for the patient to talk about the illness as well as its meaning or effect. We want to assess how much the patient knows and wants to know about their current illness and prognosis. We want to share information then based off of our patients' preferences, and respond to whatever it is that they may be sharing with us in their emotions. Similar to advanced care planning, we want to explore what their goals, their values, and their priorities are. And then at times, we make a medical recommendation for next steps in care. It's important that I took away from this research that serious illness conversations don't always result in a decision being made about a living will or a surrogate or a decision to resuscitate or not. It is, are you understanding your illness? What does that mean for you in the context of who you are as a person, and how can we make sure that we're delivering that care that aligns with your goals? So these are high quality conversations over time. They don't always happen in just one setting. They are conversations that continue over time with patients and their families. And the process of serious illness communication has been further defined and studied in efforts to scale the teaching of these skills to interprofessional clinicians of all specialties. So not just for palliative care, but for all walks of specialties, providers, social workers, chaplains. How can we all participate in the care of these patients in a way that are going to be meaningful? And so there's two such approaches that have been developed. One is called Vital Talk, and the other is a serious illness care program. Vital Talk is a training course for providers to integrate evidence-based serious illness communication into healthcare. And they basically have workshops where you come together, you learn how to have these conversations, you practice, you go through challenging cases, and you learn how to talk to patients about delivering serious news and mastering tough conversations. This is a program that we've tried to incorporate into our fellowship program to have our fellows learn how to go through some of these conversations. And it's been a really great experience and learning for them. The other is a serious illness care program, and this came out of a group that developed Ariadne Labs. It's came out of Brigham and Women's Hospital and the Harvard School of Public Health by Atul Gawande. And it basically came up with a multifaceted communication intervention that builds communication for clinicians to have sooner, to have earlier, more frequent, and more person-centered conversations. And the great thing about this is it came up with this serious illness conversation guide that can be a framework. So not just saying, hey, there's a program out here. It is, this is how you can actually do it. And so I think this may be a little small, but I wanted to just highlight a couple of areas I think have actually been really great and we've implemented into our palliative care team over the last few years here at Tampa General. It's setting up the conversation so that it is comfortable for our patients. So not just catching them off guard. Understanding what their preferences are. There's so many times when I've come in and said, hey, can we have this conversation about this topic? And I've had someone look at me and say, not today, I'm not it, I can't handle that, or I want this person here with me. So meeting our patients where they are at that moment. And language that shares the prognosis in a manner that is non-threatening. I like the terminologies that they use in terms of I am worried about this for you, and I hope for you this. And so it gives a very personalized touch to the conversation that lets our patients know that we are here really for them. It explores key topics in a way that is not necessarily scripted once you're more comfortable with the conversations. But what are your fears and your worries? What gives you strength about your future? And one of the things that I like to ask our patients about is the abilities that they feel are so critical that they couldn't imagine living without, because I think it's hard to extrapolate to the future that you could potentially be in a state where you can't move, you can't eat, you can't, and interact with your family, but tell me what's so important to you, in this moment. And I've had patients say, hey, as long as I'm sitting up propped up in a chair and I can watch some fishing, I'm good. And for me and for some of our other patients, that may not be acceptable, but here we are learning about this patient and hearing that something that is very simple, just watching something that they love to do is adequate enough for their life. And that can, adjust our recommendations later on in life for them, or even in that exact moment to say, hey, I don't think that this is going to be a real possibility. What do you think about that? Does that change your thoughts on what interventions you would want to go through? So this guide is a real great framework for all providers to use, and it is downloadable on the internet. And I give it to our fellows when we're going out to have conversations and say, hey, if you have to use it as a framework, write on it, use it, get comfortable with it, and make it your own language so that it becomes a part of your everyday questions for your patients. There's been a bit of literature that has come up around serious illness communication. The majority of it highlights clinician and patient satisfaction with education and with training about having serious illness conversations. I still think there needs to be quite a bit of definition regarding what are the outcomes that we need to focus on. I pulled a couple of articles that highlights various locations and subspecialties. This first article looked at a primary palliative care clinic for high-risk care management patients. And the patients in the clinics with the programs were implemented were more likely than those in comparison clinics to have serious illness conversations. And their providers reported high satisfaction with their training. So high satisfaction with their training meant they actually had these conversations and felt like, that they were doing a better job of communicating with their patients. This second article highlights, in the oncology world, there is a strong push and recommendation to have guidelines um, where the oncologists are talking more openly about prognosis and goals of care in serious illnesses. And the challenge for, in oncology, and as with many subspecialties and many of us, there's no major training that we go through in med school often or residency that focuses on these serious illnesses and having these conversations. And so they trained a group of oncology uh, providers, and what they found was that their patients, they said, we're not more anxious, we're actually feeling more connected with our providers, and providers felt like they had a much comfortable experience and a much fluid conversation. They got to know their patients a lot more and were able to then give the best recommendations based off of knowing their patients. This last study that I pulled looked at a general internal medicine service, and they basically looked at the timing of having some of these conversations. And for the groups that were enrolled in these serious illness communications, they were able to have these conversations much sooner with their patients than nearer to death, which we often see happen where we're called in at the final hour to say, hey, this is what's going on with your health. These conversations happened much earlier, and we were able to improve the care for patients that probably didn't have these conversations in the ambulatory setting, or perhaps didn't get an opportunity to have these conversations in the ambulatory setting. So I'm going to summarize a little bit here because there's a lot that's known, but there's still a lot that's not known. In order to make recommendations to our patients, we have to know what their patient or what their values and their goals are. Hence the importance of these high quality conversations. So regardless of where it's happening, inpatient, outpatient, there really needs to be high quality conversations. It is important for all providers to enhance their communication skills. So it is something that we train and want to become masters in the art, learning the art of communication in palliative care. But it really is important for all providers, no matter what specialty you're in, to be able to have effective communication with our patients, because we reach them and touch them at different stages of their illness, and are able to have a greater impact on them, especially when they are known to us and we've developed these relationships. There's definitely more research needed. There's a lot of challenges with quantifying outcomes, and figuring out the best way to document these discussions so that they actually get carried through and that we can follow up and piggyback off of a conversation that's been started. We oftentimes don't know when some of these conversations have started. And so there's still quite a bit of research to be done. And is there a place for both the what we would consider advanced care planning versus serious illness conversations? One of the things I thought about when I was listening to all the podcasts, or is this just semantics? I mean, we're having these conversations, whether you're in depth or not in depth, whether they're critically ill or not. Is this just, us being picky about, what we're calling advanced care planning versus serious illness? And I think I'm still working through the nuances of it all, but what I do realize is that serious illness conversations, they're much more in depth. They are much more personalized in the moment when we in the inpatient world see a lot of the critical illnesses that are happening and the ramifications of the serious illnesses that are happening. And while advanced care planning conversations, I think, are still very important to at least have our patients start thinking about who that person is that's going to help take care of them. And for some of the diseases that are very predictable in their course, or somewhat predictable, like dementia, we should have conversations with our patients about what could potentially come next. And I think there's going to be a lot more conversations about this. But I think it's about the relationships and the quality of the interactions, and that's what we as a community are hoping to improve on for our patients. So reflecting back on our patient who has this non-small cell lung cancer, we saw the patient and had this serious illness discussion, and we had a focused discussion about her goals, her fears, and just overall clinical expectations. It wasn't done solo, it was done in conjunction with the oncologist and with a pulmonary team at various stages. And after these conversations, it resulted in the de-escalation of interventions and eventual hospice enrollment. And although facing challenging circumstances, patients who have engaged in these conversations, we find that they can better understand the difficult prognostic information. They can recalibrate their hopes and priorities, and when the time comes, they can make medical decisions that are consistent with their values. And patients don't always elect for a comfort approach. They might choose intensive care. But at least we know that they have made some of these decisions, factoring in the, we know that they are knowledgeable about their disease, about what the expectations are. And then we can then engage them and their family members, and build that trust and awareness that we want to have about their care long term. So I wanted to leave you with the serious illness conversation guide that's here. Again, it can be found online at Ariande Labs. And these are my references, and any questions?
Thanks, Dr. Wilson. This was really helpful to, kind of frame for me, being in primary care, there's certain patients where it's like obvious that we should definitely have these conversations. But then there's other times where I really have to wonder, is it worth spending the extra 10 minutes in the room to start talking about it now or not yet? And so I think this is helpful to start thinking about it in the serious illness category for us.
Yeah, one of the things I didn't hear, well, I heard talked about a lot in the podcast, but not so much in the literature, is the amount of time that it takes to have some of these conversations. It's not easy, especially when you're inpatient and even outpatient when you're on a time crunch, to sit and go through this, even this guide. It's quite time consuming. I think I encourage our fellows, even while they're in the inpatient setting, that if you don't get through all of it, as you're visiting throughout the day, ask a couple of the different questions throughout. But you're right. It's how do we prioritize some of the conversations? When are they most important? And I think at the end of the day, we want to make sure we are having high quality conversations and focusing on information that's going to impact the patients most. And that's where the debate, I think, has come about. How do we have the most efficient, the best quality conversations and not just check a box? The boxes are important, but we have to go beyond checking the boxes. Any other questions or comments?
Hi, Amanda. This is Shanu. Thanks for a great talk.
Hi.
It occurs to me that these conversations are really things that need to happen when you're well. And I feel like societally have, we don't normalize or, these discussions of serious illness, end of life, needs, desires, wants. Do you have suggestions on how we can change that paradigm?
Um, I actually think at least from what I see, it starts very young in our medical career. I didn't learn about having serious illness conversations or even advanced care planning conversations until I was very late in residency and spent a lot of time in the ICU, and then realized, ready or not, here comes these conversations when people are really sick. And I was really surprised by the fact that patients didn't stop to think about it. And then I realized this is just our society view on death and dying. We really don't talk about it or embrace it. And even when I thought of my own family, like there was no serious conversations or even, even when you're watching something on television until you actually had someone hit home in your immediate family where you actually had these conversations. And so very earlier on in our medical career, I think even starting at a med school level of normalizing, death, dying, living with a serious illness first and foremost, because we have to have some, I think, more intensive training on how to have these conversations and start practicing them earlier so that by the time we're more experienced and as clinicians, it's ingrained in us. We're trained on how to do a review of systems. We're trained on how to do an HPI, but we're not really trained on how do you really sit and have a meaningful conversation and get to know a patient and what's important. So I think one of the things is normalizing it. You mentioned it's just not something that's out there all the time. Normalizing it from earlier on in our medical career, I think, is something that I would love to see happen more. And when we have our residents and our fellows from other areas joining us, sometimes you can just see the discomfort, as they're sitting there in their room. And I smile because I remember myself being the same way and thinking, man, I wish there was a way for us to, reach you all in at a lower level where you're still able to get more experience in doing this. So I think it probably starts there, and changing a little bit of our, one thing that we probably can't change as readily as society's view on a serious illness and death and dying. There's just a lot of taboo about talking about things. It's my initial thoughts regarding your question.
Thank you. And do you think COVID has changed our understanding of these conversations in any way?
I think it has. I think there are a lot of people who didn't stop to think about a serious illness before COVID. There's a lot of patients that are and families that are being impacted in a wide scale. And there's two facets. I think one, there's some patients who had some of these conversations and they were now faced with their families making decisions and going, wait, in a larger scale, going, I don't even remember what their living will says, and is it even relevant to this stage? And now we're dealing with long COVID and all the other ramifications of COVID and living with a serious illness now going forward. And then there are some who are so healthy but going, oh my goodness, like this COVID is very real. It's making us stop and pause and think about what it is important for our health. So I do think COVID has brought a lot of attention to living with a serious illness. It certainly has brought a lot of attention to death and dying and how, someone wants to be cared for at the end of their life in the hospital, surrounded by family or being away from family. So I think it has definitely been highlighted by COVID as well. And not only our patients, but providers. How do we have these conversations when we ordinarily weren't faced, right? So we had a lot of our providers being shifted to the front lines of being in the emergency room or taking care of patients that they normally wouldn't take care of, and having this uneasiness about having conversations. And so I think it's definitely highlighted a lot of our deficiencies and where we probably need to have improvement.
Any other questions or comments for Dr. Wilson? All right. Thank you so much, Amanda.
Thank you. Have a good day, everyone.